Welcome to the Food Junkies Podcast. My name is Dr. Vera Tarman, and I am your host today, speaking with Dr. Eric Westman. Dr. Westman is a renowned internal medicine physician and obesity medicine specialist with over 20 years of experience in clinical research and patient care. As the director of the Keto Medicine Clinic at Duke University and a past president of the Obesity Medicine Association, he has been at the forefront of research on ketogenic diets and therapeutic carbohydrate restriction. Dr. Westman has authored several books, for example, A New Atkins for a New You, Keto Clarity, Cholesterol Clarity, and End Your Carb Confusion. He also hosts a weekly podcast, Keto Made Simple, Learn with Dr. Westman, and offers educational programs, including End Your Cholesterol Confusion and Keto Made Simple. These are comprehensive online courses designed to demystify cholesterol, cardiovascular health, and the keto program. We had Dr. Westman on this podcast 3 years ago, and now we're bringing him back to discuss the latest developments in the keto community and new insights that have emerged since our last interview, which might aid us in our food addiction recovery journey. So welcome, Eric.
Thank you. It's great to be back.
Thank you. I'm really appreciative that you're willing to come back and update us. You picked up the history of the keto movement from Dr. Atkins and revitalized that with your book, A New Atkins for a New You. You've made your own inroads in presenting the keto community physicians and patients with metabolic disease. I see you as one of the forerunners of that. There are two communities that have emerged, the obesity doctors, of which you were the president, and a growing cadre of low-carb clinicians, not necessarily bariatric specific, using what's called TCR, or therapeutic carbohydrate restriction. So I'm curious about those two pathways and how they have evolved. Can you tell us a little bit about that historical picture?
Sure. And we really need to go back to what was called the Banting diet in the 1860s. It was the first diet book we know about in the Western world, and it was a low-carb diet. When I had two patients who lost over 50 pounds in my clinic at the VA Veterans Hospital, Veterans Affairs Hospital clinics, I was curious. Nobody really had lost weight, and so I was looking into things that could work for that, and it turned out they read the Atkins book. I visited Dr. Atkins and other doctors and really just formalized into research studies the questions about, did the Atkins diet, or low carb, or keto as it's called today, did it work? And I'd already had an inkling that it could work with those two patients. But then, was it safe, was really the subsequent question. 25 years ago, everyone thought it was necessarily bad for you and harmful. And we helped to do those early clinical trials. Now, those studies have been done all over and replicating the safety of using a low-carb keto diet. It was first known as a weight loss kind of approach. Now, Vera Health has one of the best studies done on the reversal of type 2 diabetes using a low-carb diet. They have a company that helps you figure out, using an app, and your blood sugar and ketone meters, and it's an involved way to do it, but it clearly works. Our method is much simpler, using the approach Dr. Atkins used, just by telling people, teaching them how to lower their carbohydrates. Keto, it goes much more into the metabolism. There's no such thing as a keto food. People say to me, is that a keto food? No, keto is a metabolism. It's a fat burning and ketones come out a little bit, so that's why it's called keto. But fat burning is healthy and healing for so many different things beyond the weight loss and beyond the diabetes reversal. We're really just scratching the surface. The latest information is now in a textbook, yay thick, called Ketogenic, the Science of Therapeutic Carbohydrate Restriction. And that came out last fall. I'm pretty proud to have contributed some chapters to that book. There's a saying that if the medical world, or there's enough paper together to create a textbook, that means the field has evolved to more than just a few doctors saying this. So it's been really great for me clinically because I was tired of watching my patients just get worse. As an internist, internal medicine specialist, the tools I had and what most doctors have today, it's just not very satisfying to give people medicine and watch them. We manage these diseases. And now I practice the best internal medicine of my life. I'm past president of the Obesity Medicine Association, which is mainly doctors and advanced practitioners, nurse practitioners, and PAs. But I realized that you don't need to be a physician to teach someone not to eat carbohydrates or to change the diet. So now I'm part of the Society of Metabolic Health Practitioners on the board there and advocating for this organization because we can often teach coaches, teach the super users of a particular diet how to help other people, and they can achieve, well, just as much as the doctor could in terms of teaching about the therapeutic lifestyle. And so that's why I've been involved in these organizations to try to grow the fields, although it still is mainly a grassroots change. It's person to person. It's my patients telling their family and their neighbors or at the workplace. And I'm still a little, I don't know, a little pessimistic about the top coming down and saying, this is the way we should do it.
My impression when we spoke a few years ago, we were all still at that grassroots stage, but now you're mentioning that there's a textbook, but that does indicate that it's moved up a level beyond just individual clinicians speaking. It's actually groups of physicians speaking now, enough to make a textbook. There's the metabolic health community that you belong to, people who use therapeutic carbohydrate restriction, but it seems a huge number of people, bariatric physicians in general, who are still not really getting that message. Am I not correct in this?
I think you're correct. And someone told me recently, you become a doctor to prescribe a pill or to do an operation. I'm like, no, I became a doctor to help people get better. No, the tools most physicians have, including obesity medicine physicians, are medications. And in the last few years, the weight loss treatments, including the different shots for weight loss, have just exploded, so that my colleagues in the obesity medicine world are busy, really busy getting the shots. People want them and they don't want to take time to learn about the diet. So it's really pushing the problem down the road, so to speak. But most medical doctors, even in the Obesity Medicine Association, are using the medications rather than lifestyle. Although they know about it, it's just you can't see so many people. And the clinical demand coming in is people want a shot, shot. Those are going to help a lot of people, but it pushes the question of what to eat just down the road. So eventually you have to deal with what we're talking about, or people get off the medicine and they'll just rebound and regain. We saw that with weight loss surgery, or we see that with weight loss surgery, that if you lose 150, 200 pounds on the surgery, but no one teaches you what to do after that, it still, there's so much weight regain. Many people will still regain all their weight after the surgery.
After 5 years or something like that.
Yeah.
It almost seems that the medications did a disservice. We've been talking about dietary restriction for many years, but not with much success. But now with the low carb, there is success, but then the meds got in the way, and now we have to take a back seat.
The medications, I think, bring people in the door, or bring them into the boom of weight loss. And so if we're helping to target, if you can't get the medicine, don't forget, you can just change the food. We've done it for 150 years. But you're right, it's a big distraction, and people, including doctors and companies, want to make money from those things. And very little money is made by telling someone not to eat carbohydrate. It doesn't make practitioner much. There's no procedure. There's no company coming in to help you. Hopefully, at the end, it will help people at least get into the process of weight loss. They'll start feeling better. And if they can't continue on medicine, they'll seek out other alternatives.
One of the concerns that I have is with the manipulation of hormones. And eventually, I'm sure there will be some tolerance because that's what happens. The body homeostatically will adapt.
Yeah.
There'll be new medications and tolerance will follow, and then more medications. Are we eventually going to get ourselves caught into a problem where we're going to be tolerant to virtually everything, including our own natural ability to satiate, like when we have to get off these medications? Are we not doing our bodies damage in the long term? Am I being pessimistic here?
I think realistic. There's so much not known about it. So the GLP-1 is the type of injectable or shot
Yeah.
that targets, it's basically a hormone the stomach and GI tract secretes after you eat. So it tricks your brain into thinking that you've already eaten. That's the first generation anti-obesity medicines, or AOMs they're called. And then the second generation are the GLP-1 and the GIP combination effect. There are now third generation ones
Yeah.
that are being made. So it is almost like an escalation. When this one stops, you go on this one. When this goes, and what happens internally, God only knows, right? It's just a matter of time. In the studies, the companies are already testing, well, if people lose weight over a year, let's randomize them to placebo or continued medicine.
Yeah.
And since they're not teaching people what to eat, if they randomize them to placebo, the weight comes back. So they're arguing you should just keep people on their shots forever. The companies love the idea that you'd be on it forever. And I think that's a legitimate concern. It's not being pessimistic, it's realistic.
Since you've been speaking, because you have your course on cholesterol clarity, and others are speaking, Ken Berry, speaking about cholesterol and how we've been viewing this the wrong way. Do you feel like there's been any change in the sort of standard cholesterol hypothesis from cardiologists? Are they still holding on to the old truth?
I guess to put context into it, for a long time, the only prevailing theory about cholesterol causing heart disease and atherosclerosis was about LDL, the
Yeah.
LDL cholesterol being the cause. And you can look, there are hundreds of papers, scientific papers, that basically get away with saying it's the cause when it's really not that clear. But that's the prevailing wisdom. A growing number of doctors and a small amount of cardiologists, very small, understand the term metabolic syndrome.
Yeah.
And metabolic syndrome is also known as the residual risk. So even in the old paradigm, LDL comes first, and then there's this weird thing we don't know what to do with, the high triglyceride and the low HDL. That, we think, is the predominant feature that you want to tackle. That's a small minority of people, I'm afraid. I think that the upshot of what we've learned is that the metabolism changes on a low carb diet, much if you're driving on the left-hand side of the road or the right-hand side of the road. The rules are different, and you still can get from point A to point B in that country, but you do it differently. So the blood work looks different. And because of the old mindset of, if it's different, it must be bad.
Yeah.
That's what we're struggling with. It's a clash of, if you have only viewed LDL cholesterol as a bad thing, not something that carries cholesterol and other fat-soluble substance around the aqueous bloodstream, which is what it is. It's actually in there for a reason. If you only thought that it was bad, then you're going to knee-jerk reaction that if someone following a low-carb diet has an elevated LDL, it must be bad. And that's the way I thought of this 25 years ago when I first got into it.
Yeah.
Now I've seen so many people improve everything else and not developed heart disease over time that I've personally started to question the whole LDL idea, or at least under the circumstances, the context of a low carb diet, that it doesn't have the same connotation. And now finally the science is coming to a study. People would say that it's a small study, about 100 people with really high LDLs who say they've been following a low carb diet. They're called the lean mass hyper responders.
Right.
And it's just a heroic story of a GoFundMe project nobody, the lead investigator, Dave Feldman, would
Yes.
knock on doors and no one would help him. They would say, no, don't do that. You're crazy. He's a lean mass hyperresponder himself. And he went and got one of these CT angiograms and it was normal. And so he came up with the idea, let's send 100 people to the best scanner in the world, which is in Los Angeles. And so the 100 people were flown out there and have scans, and the initial results were supportive of the idea that not everyone gets the disease, and people who've had really high LDLs for over 5 years, some of them had no evidence of coronary disease at all.
Yeah.
So that the idea that it's always a bad thing, that you should worry about it all the time, no, I don't think that's the case. Should we forget about it and say it doesn't matter? No, I don't think that's the case either. But organizationally, the cardiologists that I know who are open to the idea of metabolic syndrome, that triglyceride and HDL in the blood are worthy to target,
Yeah.
they still have the old paradigm because they live in that world of, if you don't at least pay homage to LDL and the reduction of LDL with a drug, you're so far out of the medical mainstream that they still have trouble not.
The fringe.
Yeah. But if you get access to money to fund it, the science will win. We'll find out an answer.
For our listeners, I want to clarify. The LDL hypothesis is supported by the pharmaceutical industry because that's where the statins work. So they have an investment to making LDL the main player. The lean mass hyperresponders, just for people who don't know what that is, do you want to define what the criteria of that are?
There are specific numbers. So it's a really high LDL.
What's normal and what's a hyperresponder?
Yeah, most doctors would think an LDL of 100 or 120 or 130 is the cut point for when you would use a medicine. 100. So this is 2 to 3 times to 5 times that high.
Yeah, like 300 or 400.
Yeah, and in fact, in the study that they're doing, there's someone with a LDL of almost 600.
600, wow. And so for Canadians listening, that would be 5 is normal-ish, about 5, and we're looking at 7, 8, 10. Yeah.
Yeah. And I actually know the person who went into the study and has had that. One of the flaws or limitations of the study is that people are self-reporting doing this for an average of 5 years.
Yeah.
Now, while they're in the study, they have to document what they're doing, and they're going to be repeating that scan at a year. And the very interesting thing in the blood is that the HDL, the good guy, if you will, good cholesterol, was really high.
Yes.
And if you really want to put both paradigms together, it would be that the HDL counteracts the LDL.
Right.
And that might be a way to think about it. I don't know if that's really the mechanism of what's going on, but triglyceride goes down.
You have low triglycerides, high HDLs, high LDLs, and your blood sugar is great, right?
Yeah, and so in the Vera Health study, one of the best comprehensive looks at metabolism of people doing a low-carb keto diet, pretty much everything else gets better, goes in the direction you want, but except for that LDL. And it was presenting that information at meetings that I finally woke up one day and said, maybe raising the LDL is a good thing. If everything else got better, why would just one thing not get better? So maybe I started thinking, maybe we just have the wrong perspective of what's going on, coming in with a preconceived notion. But yeah, blood glucose gets better, improves, normalizes, basically. And just to reassure people, I think the metabolism is just running in a different way. And just because we're measuring a blood test and it has a certain connotation when you're eating carbs, it doesn't necessarily mean the same thing when you're not eating carbs.
I do see people, even who follow the lean mass hyperresponder hypothesis, when their LDLs get really high, I still see them getting nervous. I guess it's like we're just nervous to let go.
Yeah. And if you hit the medical world, it's still 99% of the time someone's going to give you grief about it and want you on a medicine. But there's so much fear mongering about it. I envisioned the cartoon. I need to commission it, I think, where keto causes heart attacks, and it's the doctor reading the LDL report who's
Yeah.
getting the heart attack, and
Oh,
the
yeah.
patient sitting there, what's going on? Other people get so worried about it. For me, it's been 25 years of watching this over
Yeah.
time. I don't see that the end of the world has come about this cholesterol reading.
In the lean mass hyperresponder community, the people who say, okay, if my LDL is high, if I cut down the saturated fats, they will normalize. So we should use polyunsaturated fats instead. And so what's your take on that?
You can manipulate the blood by changing the food. And there was an interesting paper where they took a clinical group, took people who had that lean mass hyperresponder blood
Yeah.
response, and then they gave them back more carbs, and the LDL went down, and they changed the saturated fat. So you can do that. I just don't know that it's
Useful
necessary.
because we're like you said, maybe LDL is actually a positive thing when the other parameters are normal.
It would almost be like, let's go to a country where they drive on the left-hand side of the road, and let's just go halfway into that lane. Yeah, that
Right.
doesn't work. Just go down the middle of the road.
Yeah.
The saturated fat in the food has been targeted for decades.
Yeah.
And that was really part of the whole industry creation of these terrible foods that had no fat in them, but had tons of sugar and starch. And most people now think that's really what created the obesity and diabetes epidemic that we're in.
Yes.
It was the creation of these fake foods, the highly processed foods, and also then the staying away from the saturated fats. The researchers have known for a long time and came together in a consensus statement maybe 5 years ago worldwide. Researchers saying saturated fat is not a problem. It's not a health concern. It takes time for researchers to pass the baton to organizations.
Yes.
And then whether or not that gets passed to the governmental folks it's a political process. They don't always follow the science. And if your organization was founded on the belief that fat in the diet is bad, it's always going to say that. And that's the American Heart Association. They were founded on the belief that saturated fat is bad. It would be like going in to say the Catholic Church would change its rules and say there is no God. It's not going to change.
If a person has had a heart attack, so they've got end stage organ damage, like they're already crossed the line, would you recommend a keto diet for recovery?
Sure. Yes, I would reduce a diet that lowers inflammation. And that's what a keto diet. I might also recommend medication from the old paradigm view to lower inflammation as well. So I'm not anti-drug by any means, but I think anti-inflammatory diet is what you want. The inflammation is what starts and perpetuates the atherosclerosis on the arteries. The heart itself, the muscle loves fat. In fact, it runs on the fat. The arteries, the pipes that go around get inflamed, and then the damage, arterial narrowing, is from that inflammation. And of course, the heart has an electrical system that loves ketones. And so I'm very comfortable with a keto diet as a recommendation if someone has heart disease. The heart surgeons at Duke send their patients to me who are too heavy to be transplanted. So I see people who have heart failure, and many of them now have a pump implanted. It's the oddest thing. First time you listen to the heart, you don't hear a beat, you hear a whir. It's a continuous slow pump. So they're not worried about me making the heart failure worse. They just want
the steaks and the fat and all that stuff.
No, yeah. In fact, there seems to be an underground movement among cardiothoracic surgeons that they're okay with this. In fact, Dr. Phil Ovadia is a cardiothoracic heart surgeon who has a book, Stay Off My Operating Room Table, by eating a low carb kind of diet.
Okay, good. Some questions about the keto world. Why is it that some people really do well on keto, they thrive, and others really struggle. And it's not just the food addiction piece because they're sneaking keto treats in there. They just don't seem to do as well. Is it a genetic thing? Is it their level of insulin resistance? Do you have any thoughts about that?
That's a great question. If I had all the money in the world with research, that's one of the things that we would target. I don't know exactly. My sense is not the metabolic issues, because all of those get better.
Yeah.
It's more the brain is connected to the body, and it's more the personality style. The people come to me, they say, I'm happy just eating anything. Actually, that's kind of me. I'm happy eating the same thing as long as it's nutritious. It's one less decision I need to make, three less decisions I
Yeah.
need to make throughout the day. And then other people who come to it with, I need something every day. It's
Yeah.
different. And food becomes more of their not only culture, but
Emotional.
personal being. I used to help people quit smoking as a job, worked with the
Yeah.
inventor of the nicotine patch and used medications, but behavior was still a large part of it. And people
Yeah.
would say, I love smoking and I loved it, but I know it was harmful. Now with food, people even come in and pantomime eating food because it's a part of their being. Or I wonder if there's a construct to see how one is related to that element of life,
Okay. Yeah.
how much they're willing to give away their favorite food in order to gain a certain level of health. But if you could reverse your type 2 diabetes
Yeah.
and not get shots anymore by changing food and just for a temporary period of time, most people would at least give it a go. And that's the other element that some people come to it. Does this mean I can never have fruit again? And then there are other people who just go step by step into it. It's one day at a time. I wonder if that's more related to anxiety or mental
Something about
health
the person.
issues. People tell me that my family always grew up, I'm Italian, I can't give up pasta, or,
Right.
I'm Greek. I think it has to do less with the metabolism internally, but more with how we view the food as an individual or a family.
Okay. Now, the ketone diet. So a person is following strict keto, like you suggest, 20 grams or less. It seems to really reduce food cravings. And my understanding of that is because you've removed the addictive food, and so the cravings are quiet. But do you think there's something about ketones themselves? They satiate seemingly better than a carbohydrate diet, which just makes you hungry. But do
Yeah.
they also cut carbs? Just the fact that it's ketone based, you're fat based.
I think you're right. The cold turkey method for getting over addictions is
Yeah.
really what's going on for sugar addiction when you cut out all the sugars and starches.
Yeah.
You have to remember that starches get digested to sugar. So you might give up everything sweet, but you're still ingesting the addictive substance, the pasta, the rice, the
Yeah.
fruit, that's the thing. The ketones themselves, it's been a little underwhelming to see the effect of just ketone drinks, for example.
Right.
Or,
Yeah.
but I have to say that I'm also disappointed the companies haven't done due diligence into really spending money into how to use the ketones clinically. And many of them went out to just start selling the products without evaluating the effect in the clinic in a formal way. But so ketones themselves are molecules not only of energy, but they do give signals to the genetic code, change genetic expression. They are anti-inflammatory. And the initial effect of people drinking ketones can be actually one that cuts hunger out. But I think the craving reduction of a keto diet is because you're getting away from the addictive element.
Okay.
So
All
there's a
right.
withdrawal, but the withdrawal period varies. It could be no withdrawal at all to people say it took me a week or
Yeah.
two to get
Days to
over.
weeks. What about fat? Eating too much fat can be addictive too.
Sure, depending on what form the fat is in as well. There's a thought people can get off the sugar addictive nature and get on the fat. I don't have a whole lot of clinical experience with that. If someone does my program and does well, they typically come back. If someone is hooked on something else, I'd love to do some research on that because a lot of people start thinking if it hasn't been helping, I'm not having success, I won't go back to see that doctor, even though
Yes.
I'm there to help. So I'm afraid if there is a cross addiction to fats, or it
Okay.
might be in a form of dairy. It's hard for people to stop cheese. I've met people for whom a jar of mayonnaise is a serving size.
What's your opinion about the processed food industry moving into the keto world and starting to make all sorts of keto products? And I'm thinking about things like pork rinds. That's clearly processed. Are they okay? Are cheese crisps okay? They're not
Yeah,
carbohydrates. What's your thoughts?
so it's good and bad, right? Actually, I do prescribe pork rinds. I do prescribe cheese crisps.
Yeah.
To me, to say something's processed doesn't really tell you enough. I'm always kind of saying, you got to look at the carbs. Let's talk about carbs. If you lower the total carbs under 20 per day, you're not going to get many of these ultra processed foods.
Uh-huh.
And in that case, the pork rinds are fine because they have no carbs. They don't raise the blood glucose. They don't raise the insulin. They don't stimulate the addictive process. Cheese crisps, for a long time, people would make their own on the parchment paper in the microwave. Now you can purchase them at the store. They can be overconsumed very easily. And if you're trying to limit calories and the fats, in our program, we help you understand that you have to limit the fat and the dairy category. What we're seeing in our area, though, is products labeled keto, keto ice cream,
Yes.
keto bread, keto this, keto that. Stay away from those things if you're trying to do a keto diet. But the fact that they're out there, they have less carbs, probably in general is a good thing compared. So if you're not doing a keto diet and you don't need a keto diet, it's better that you have less carbohydrate than before. But I really don't know who's advising the industry, because there was a keto coffee because they just sprayed a little MCT oil on the beans,
Yeah.
which no is not going to give you much MCT.
No.
And then other people other companies are putting sugar alcohols in there that can interfere with the metabolism. So in my program, I advise people to stay away from products with the keto label on it, because there's no control over what keto means in those processed foods.
Now, you mentioned sugar alcohols. So that's like, for example, allulose, which is very popular right now.
Yeah, allulose, there's some research now coming
Yeah.
out, and they even gave allulose to folks who weren't doing a low carb keto diet to see what would happen with diabetes. I'm still on the fence. In my program, I ask people to count total carbs, which means the sugar alcohols and the fibers are all counted. So
Yes.
my version is really strict. If you are following someone on the internet that really doesn't need a keto diet, they could be pounding fat at 150 grams a day, and you want to be careful of who you follow. But in general, the content of these foods have less sugar, which seems to me to be a step in the right direction.
I think you mentioned something about this, those exogenous ketone drinks or supplements. What's your thought about that?
I'm really disappointed that the
Yeah.
companies haven't ponied up the studies
Okay.
for us to know. If I had all money in the world to do studies, that's one of the first things I would do. Does adding a ketone supplement, or even apple cider vinegar or bulletproof coffee, one of these internet keto, we call it, constructs, does that add value to the program that I already teach?
Uh-huh.
Because what I teach has such a history with it. I've seen these other things make it worse. Of course, then you have to pay for these products. For a long time, I was teaching low carb and keto, which is Atkins induction, in the clinic. And then people started coming in saying, well, that keto, it's so expensive. And I said, what makes you think that? So they started talking about buying all of these keto things that I don't recommend. And there's even like keto gummies that are being pushed out there, or Shark Tank or TV things. And there's very little research to guide us on that. So it's really let the buyer beware.
The new keto meter, you can stick on like a continuous glucose meter. What do you think about those?
If you want to know the blood glucose levels, that's the continuous glucose monitor or CGM. I don't yet have many patients using them. I don't know, which is the requirement that I need before I'll recommend something like that. A, they might not be as accurate as everyone says. B, they might be super expensive, making it out of reach for a lot of people. But no question, these meters help people, some people stay on track, especially if you're someone who's lost confidence in the doctors or the dietitians. Nothing's ever worked, and you don't believe me that if you don't eat carbs, your blood glucose won't go up, then by all means, get a meter. We can now get over the counter without a prescription, a CGM at least. It's about, I don't know, $80 US for a month. And you can get that the level. When I wore a CGM, though, at the end of the month, I had a higher blood glucose because I tried to see what I could get away with. Right. Came in super strict on my program. My blood sugars were 80s, 90s, and then can I have that chocolate croissant that I liked from living in France? Can I go to Starbucks and get the latte? And by the end of the month, my blood sugars were in the low hundreds. Not terribly bad, but especially if you're coming to new to this, I don't recommend them, because I know that if you stay to the list of foods that I give, that everything is going to, the glucose is going to come down.
So tell us about your program and then about your course, which I'm assuming is the explanation about the program.
Yeah, so the work that we've done at Duke over the last 20, 25 years in terms of research, validating the kind of program that I use. So we did research on it and then started a clinic using the approach. It's very simple. I hand out one sheet of paper. In fact, if you come to the office, I have the 4-color version on the wall, so you can read it as you're there. And basically, we take the carbohydrates down to 20 grams per day. That's total, not net. And it's remarkable how many things get better. In fact, it's so unbelievable. You wouldn't believe me in a medical system how many things get better, the chronic medical problems.
How quickly does it get better?
Depending on the problem, in a day. So one person was drinking so much Coca-Cola that had sugar in it and using insulin that on the day I advised him not to drink the sugar in the drinks, his blood glucose normalized, coming off the insulin. So the weight loss typically is 1 to 2 pounds per week. The hunger, though, going away in 1 to 2 days, as fast as using a medication. We did so because of 2 of my patients, I was curious, went to visit doctors who had really worked this out and used it for decades in their own clinics. We published papers, and now other people have published similar types of papers to validate that. And it really is bringing us back from the internet keto confusion to a simple system that pretty much works if you do it.
Okay, so there's the 20 grams or under, and what else?
The system that was worked out is based on basic nutrition. The protein comes first. Protein is what we're made of. If you look at a body composition analyzer, we're made of protein and water.
How many grams?
It's really variable. You eat until you're comfortably full. So the list that we have has a section of the proteins. It's meat, poultry, fish and shellfish, and eggs. And there are a few pivotal classic studies now where they put people on a research ward and told them to eat this way, and they ate as much protein as they needed. You didn't have to tell anyone how much protein to have.
They could eat 2 pounds of steak a day would be okay, like a pound at lunch and a pound at dinner.
The interesting thing about that, I've had people do that, but after time it wears off. And you don't do that very long. So there's a lot of weirdness that happens in that first week. I remember vividly, I went through bowls and bowls of sugar-free Jell-O to try to get over the sugar addiction. And so some people, one fellow said, I have 3 pounds of bacon every day. And I said, Lord, but then he said, it didn't last very long, just a few days to get over the hump. There's a lot of strange things that happen in the first week or two, but you eat protein. So protein comes first. We prioritize the protein.
So
You can
protein
have
to satiety.
2 cups of leafy greens, and a cup can be estimated by a fistful. You just
Okay.
take a measuring cup, compare it to your fist. 2 cups of leafy greens, 1 cup of a non-starchy vegetable, and you could, if you want, have cheese, cream, mayonnaise, but there's a limit to those because they're such high fat items. And so we've taught enough people now using our Keto Made Simple class that's available at Afterlife Academy, and it's open right now. It's going to be available only for until Monday, October 7th. We enroll people through the internet into a class, and we've taught now over 5,000 people how to do this on the internet. And we compare then what we teach to them, and the big items are that people thought they could have all the cheese they wanted.
Yeah.
Internet keto doesn't teach a limit on the cheese, the cream, the mayonnaise. It's, well, there are no carbs.
Yeah.
And internet keto in general teaches net carbs, which allows you to have all of those keto products that really don't help.
And internet keto, it's not clear about what kind of fat and how much fat either. Like in some cases, they say eat as much fat as you want. I'm sure you clarify that.
It turns out if you stick to real food, and that's an important part of the program, don't eat fake foods and highly processed foods. If you stay to the real foods, you get the fat that you need. Fatty acid deficiency, that just won't happen. But if you're trying to lose weight, you want to burn the fat off your body. You don't want to be consuming fats. And we don't use apps. We don't use macro counting. We don't use any requirement about super clean or organic foods. My clinic is in the heart of Durham, North Carolina. It's a very working class area. I had a patient just eat at McDonald's. He lost 100 pounds. He chose wisely to not eat the buns, the fries, and no sugar in the drink.
But he still went to McDonald's and ate their burgers?
Yeah, 2 or 3 double cheeseburgers, just no buns. Yeah. So how is that for the people who are obsessing about super clean foods and fast food is evil? And so I have to meet people where they are and figure out a way. That's where the pork rinds come in. It's like a comfort food here.
Yeah.
Although I was traveling in some years ago in Montreal, and there was this thing on top of the food, the dish, and it was this amazing exotic thing. It was a pork rind. And if you think that's something that's not healthy, you don't have to have it.
Yeah.
But I'd rather have you have a pork rind than a Twinkie.
What else can you tell us about the course, which for anybody listening needs to sign up by Monday, October 7th? That's the end of the sign up.
We bring people into a exclusive private social media group, Facebook group. And so you get to learn from people who our admins basically help you with any question that you have. Although the course itself is video content that I give the classes. I try to break down basic nutrition, what keto means, how to start it out. You can do it complicated or simple. These major things we've talked about, how to look at the blood tests differently than a lot of doctors are currently looking at them. All of that video content is available in PDFs as well, so that if you learn by reading or by watching the videos, it's all there. You actually get access to that content forever, so that it's not, the Facebook group is 3 weeks to get you over any hurdle of getting started or fear of the inertia of just getting you going. But the content itself in the class is yours forever.
I'm really gratified by your work, and also that you specifically have been very open to the message of sugar addiction and food addiction, or the addictive piece that people have to struggle with and confront when they're starting their keto diet, because it's keto flu in that first week, but it's also withdrawal from sugar.
Yeah, withdrawal from sugar. And I have to say, I went back post-COVID to the Obesity Medicine Association, and a friend of mine who I hadn't seen for a couple of years came up to me, and he said, "This is the first time I've heard you talk about sugar addiction."
Oh, yeah.
He was excited about it because apparently he had said it all along, and whatever. So I have to thank you for helping me learn about it.
Yeah, thank you. Did you want to say final words about your program or about the course?
I think if you're struggling, why do you keep going back to sugar? Why do we self-sabotage? Why must I be in this cycle? We get into that and just explain the different metabolism that also happens when you don't eat carbohydrates. It reverses obesity, type 2 diabetes, fatty liver, really all of the chronic medical issues that we have today. And then we introduce you to the idea of ongoing support, which is another valuable thing that you taught me, that with true addiction, you need to have some sort of support system. The advantage of doing it online is that you don't have to travel to North Carolina. You can do this in the comfort of your own home. And there are so many different ways to do it. We give you basically the basic understanding of what to do, and then you can choose the type of food, where you get the food, how to do it. The tactics are really up to you. My admins are fantastic. They have been through it themselves. They're so devoted that you're going to get responses as you get started. There really is no course like this that teaches you and then actually walks you through it in the first 3 weeks. And partly it's because the method that I learned was something that had been worked out for years and then just forgotten.
All right. Thank you so much for joining us on Food Junkies again.
My pleasure. Thanks for having me.